clinical transfusion guidelines. So, the clinical transfusion guidelines has been formulated to avoid unnecessary and unsafe blood transfusion. So these unnecessary transfusions and unsafe transfusion practices, they expose patients to the risk of serious adverse transfusion reactions and also transfusion transmissible infections. These unnecessary transfusion, they also reduce the availability of blood products to patients when they are in need. So this unsafe or unnecessary transfusion may lead to errors in transfusion. And these errors in transfusion leads to serious consequences in terms of both mortality and morbidity. And the most common causes or frequent causes of errors in transfusions include incorrect sampling of blood from the patient, fetching of the wrong unit of blood from the blood banks, and inappropriate transfusion practices both in the blood bank and also in the wards. Now, for this, to minimize this, WHO has formulated some guidelines, and there is a standardized approach to minimize the errors and also to administer safe and efficacious blood. And this WHO guidelines also provide protocol for investigation and treatment of adverse transfusion reactions which happen due to any transfusion, blood transfusion. And this WHO also give a proper guideline how to use a blood and also how to use specialized blood products. Now, coming to the principles of blood transfusion. The main principle is to give safe blood, and the blood is taken from a safe donor. And the blood transfusion services has to be responsible, and the use of blood should be appropriate. Now, coming to the safe blood. The blood has to be collected from a carefully selected healthy donor. So who can be a healthy donor? A safe donor is a donor of the age group 18 to 65 years. He should be healthy and his weight should be more than 50 kilogram and hemoglobin more than 12.5 gram per deciliter. And also he should not have any risk factors for HIV or any other transfusion transmitted infections. For a healthy male, he can donate blood every 3 months, and for a healthy female, she can donate blood every 4 months. Now, the blood has to be processed in a reliable, responsible blood transfusion service. And the blood transfusion has to be done only upon need and for the patient's health and well-being. Now, the blood transfusion service has to be responsible. So these services has to ensure appropriate and safe processing and testing of blood. And they should have proper screening methods and also cross-matching methods to avoid unnecessary complications while transfusion. Now, appropriate use of blood. It is to provide right blood component to the right patient in right quantity at the right time in right quality. So, whenever a patient comes with acute blood loss, never ever start a blood transfusion as a first resort. So we have to do an effective resuscitation first. And after that, assessing only, we have to go for a blood transfusion. And never consider hemoglobin value as the sole deciding factor for blood transfusion. We have to think about the circulatory status, oxygen requirement, red cell volume of the patient. And previously, a 30-10 rule was used for transfusing blood. That is, if the blood hemoglobin level was less than 10 gram per deciliter or hematocrit was less than 30%, blood transfusion was considered. But nowadays, hemoglobin value is not the only factor. So the normally the consensus is that we are using less than 6 or 7 gram per deciliter is considered to be the limit for transfusion of blood. Whenever the blood hemoglobin value is less than 6 or 7 gram per deciliter, we administer blood. But transfusion above this level, that is if the HP level is more than 6 or 7 gram per deciliter, transfusion has to be according to the symptoms of the patient or estimated blood loss during the preoperative period, or also regarding the cardiovascular or pulmonary comorbidities the patient has. And blood transfusion has to be started only when benefits outweigh the risk. And during transfusion, proper monitoring of the patient is very essential, and we have to timely respond to the adverse reactions. Now coming to the processing of blood, this is done in the blood bank. So first we have to, after collecting a blood from a donor, it has to be screened for 5 diseases. It includes HIV, hepatitis B, hepatitis C, then syphilis and malaria. Out of this, HIV, hepatitis B, C and syphilis are done using ELISA method, and malaria is by rapid cards. Then we have to separate the blood into components if required. The components are packed RBCs, platelets and plasma. So now some basics about blood components. Blood contains mainly plasma and cells, and these cells include RBCs, WBCs and platelets. Now blood products are broadly divided into whole blood and blood components. Whenever whole blood is taken, we are using a single bag, blood bag. So 350 or 450 ml of whole blood is collected in a single bag, which contain either 49 or 63 ml of anticoagulant preservative solution. And this anticoagulant may be CPDA or SAGM. And depending upon the anticoagulant solution present, the shelf life of the bag varies. That is, when the anticoagulant solution used is CPDA, the shelf life is 35 days. And when SAGM is used, the shelf life is 42 days. Now this whole blood has a hematocrit of 35 to 45%. And in whole blood, the platelet function and coagulation factors activity are absent. That is, the activity of coagulation factors and platelet function is deranged at a temperature of 2 to 6 degrees Celsius, which is in this temperature only we are storing whole blood. Now coming to the blood components. They are products separated from a single unit of whole blood. And thus blood components are separated for the rational utilization of a scarce resource, and also for the optimum preservation of blood component function. For example, platelets. Platelet function is preserved at a temperature, at room temperature. Then out of group transfusion is possible in some blood components like platelets and cryoprecipitate, and they have lesser logistic problems. So now coming to the types of components, I already told cells and plasma. Cells are divided into RBC, platelet and WBC. And the RBC, we have PRBC, that is packed red blood cells, and some specialized products, which include leukofiltered or irradiated or washed or frozen RBCs. Now coming to this leukofiltered, irradiated or washed, these specialized products are leukodepleted cells, that is WBCs are removed from the PRBCs. These are actually removed because this WBCs cause febrile transfusion reactions in a recipient. So in order to avoid that, we have to remove the WBCs from the PRBCs. So these are usually given in patients immunocompromised or organ transplant patients to prevent the graft versus host disease. Then this leukofiltered is, there is a filter, aggregate filter, which is used and PRBCs pass through that. So WBCs, donor leukocytes, are filtered from that. And irradiated means gamma irradiations are used. So such blood units have to be used within 28 days. And wash means saline wash. That is, PRBCs are washed around 2 to 3 times in saline. So WBCs are removed, so it can be used. Then frozen and deglycerolized, that is, RBCs are frozen at minus 196 degrees Celsius, so that it can be kept for up to 10 years. It can be kept. Now coming to platelet. Platelet, we have platelet concentrate and platelet rich plasma. So platelet concentrate, they are separated within 6 hours of collection of blood. So platelet function, I already told, it is platelet has the maximum function at room temperature. So it has to be separated before taking the blood or keeping the blood inside the cold chain, that is 2 to 8 degrees Celsius. So before going into the blood bank refrigerator itself, it has to be separated. Platelet has to be separated, and it is stored at 2 to 20, that is at room temperature, to maintain its function. Then we have WBC, that is granulocyte concentrate, that I'll come in detail. The next is plasma. Plasma has fresh frozen plasma, cryoprecipitate, and plasma derivative. Then fresh frozen plasma is separated within 6 hours of collection. And this fresh frozen plasma can be kept up to 1 year. And while issuing, it has to be thawed. It is kept at minus 40 to minus 80 degrees Celsius. So it is very frozen. So whenever there is, we have to issue that, the FFP is taken out of the deep freezer and it is thawed at 30 to 37 degrees Celsius, and it is brought to the room temperature, and then it is issued. And once thawed, it has to be used within 6 hours at room temperature if it is kept at room temperature, or 24 hours if it is kept at 4 degrees Celsius. Now coming to cryoprecipitate. These cryoprecipitates are actually the fresh frozen plasma is taken and it is thawed at 30 to 37 degrees Celsius, and then it is kept at room temperature. So then some precipitate will be formed, and this is the cryoprecipitate. This is rich in fibrinogen and factor 8. So in hemophilia patients, we use cryoprecipitate. And the rest of the plasma which is left behind after preparing the cryoprecipitate is cryopoor plasma. And then we have plasma derivatives. Now these components are separated using 2 methods, either sedimentation or centrifugation. We are using centrifugation, that is cryofuge. It's using a machine called cryofuge. It's a bigger centrifuge in which blood can be centrifuged at different specific gravity for a fixed time. So we can set a timer and we can program this, and we can do that. Now coming to the indications of PRBC. Usually PRBC is given in case of patients with hemodynamically stable anemia, where the transfusion trigger is 7 gram per deciliter. And also in acute bleed based on the clinical status. That is generally if the blood volume loss is more than 30%, or when the patient is having stage 3 or stage 4 shock. Also PRBC can be given in case of thalassemia and sickle cell anemia, when the maintenance is 9 to 10 gram per deciliter. PRBC can also be given in case of elective cardiac or orthopedic surgeries or pre-existing cardiovascular disease. Here the trigger is 8 gram per deciliter. Now the platelet concentrate indications are bleeding due to thrombocytopenia or platelet functional defects, or to prevent the bleeding. Acute DIC. Then in case of elective surgery, including insertion of indwelling lines, transbronchial biopsy, liver or renal biopsy, neuro or ophthalm surgeries. Now coming to fresh frozen plasma. Fresh frozen plasma, as I have already told, it is kept in deep freezer. That is either it can be minus 40 or minus 80, and it can be kept up to 1 year. And it comes in around 200 to 300 ml pack, and it contains all the clotting factors, albumin, immunoglobulin, etc., and also factor 8. And these are transfused over half hour. And if they are not used immediately, we have to keep it in blood bank refrigerator, that is at 2 to 6 degrees Celsius. And its dose is 15 ml per kilogram. Now, its indications of fresh frozen plasma include raised PT, APTT, or INR above 1.5 normal. And also in chronic liver diseases or DIC, that is multiple coagulation factor deficiencies, or in case of thrombotic thrombocytopenic purpura. And they can also be used when we need a reversal of warfarin effect, when we do not have prothrombin complex concentrate to be given to the patient. Also, when there is any specific factor concentrate is absent, we can give for any single coagulation factor deficiency also, we can give this fresh frozen plasmas. Now coming to cryoprecipitate, I have already told how it is prepared. It is prepared from fresh frozen plasma. So cryoprecipitate is rich in factor 8 and fibrinogen. It contains around 80 to 100 international unit per pack, and each pack contains 15 to 20 ml of cryoprecipitate. And fibrinogen is 150 to 300 international unit per pack. And this is used in case of hemophilia patients. Fibrinogen less than 100 milligram per deciliter, or as an alternative to factor 8. Factor 8 can be obtained as a preparation. We can buy it from pharmacies and all. So otherwise, it can be used as an alternative for factor 8 in hemophilia A or von Willebrand's disease, or as a source of fibrinogen in congenital or acquired fibrinogen deficiency. So the importance of cryoprecipitate is that it is not group specific. So any group of cryoprecipitate can be given to any group people. Now coming to granulocyte concentrate. So they are indicated only when the benefits outweigh the risk. So in case of severe neutropenia, which is associated with bone marrow failure, as in aplastic anemia or chemotherapy, with sepsis unresponsive to antibiotic therapy. So only in such cases, granulocyte concentrates are given. So once prepared, it is stored for only maximum of 24 hours, and it is stored at room temperature. Now we also have plasma derivative. These are prepared industrially. So it includes coagulation factors, plasma proteins, immunoglobulins. And coagulation factors include factor 8 concentrate, factor 9, and antithrombin 3. Plasma proteins include albumin and plasma protein fraction. Then immunoglobulins include non-specific immune serum globulin, Rh immune globulin, hepatitis B immune globulin, varicella zoster immune globulin, tetanus immunoglobulins. Now, how they are stored and transported? Usually, whole blood and PRBCs. They are stored at 2 to 6 degrees Celsius in blood bank refrigerators. And they have a shelf life depending upon the anticoagulants used, 35 days or 42 days. Now, platelets are stored at room temperature to prevent the destruction or to prevent the function, to maintain the function of the platelets and the coagulation activity. We are keeping it at room temperature, and it is kept in a separate device called platelet agitator. That is, the platelet is always in a agitated continuous motion to prevent the platelet clumping. Then the plasma, fresh frozen plasma, is always kept in deep freezer. It can be kept up to 1 year. And platelet has a very short shelf life, that is 5 days only. And this are transported to the ward using containers having temperature display. It is very important to maintain the cold chain. Blood should never be stored in water refrigerators under any circumstances. This is because water refrigerators may not be temperature monitored frequently, because in blood bank we monitor this every daily basis, every 3 times in a day, we are monitoring this. And also the water refrigerator may contain many other medicines and all, so chance of infection is very more. Now, why there is a need for blood transfusion? Blood transfusion is always done to restore blood volume, as in case of any blood loss, in case of any severe hemorrhage, trauma, accidents, or anything like that. Then replace clotting factors in case of hemophilias or clotting factor deficiencies. Then to improve oxygen carrying capacities in patients with severe anemias. Then to restore blood elements that are depleted. For example, in case of leukemias, aplastic anemias. Then to prevent complications of severe bleeding. Now, when? That is the same thing. That is significant blood loss due to injury or surgeries, anemias, bleeding disorders, burns, liver failure, severe infection, and also in exchange transfusion. Now, this is more important. This is what we have to do in our wards. That is how we have to transfuse blood. That it is divided into before transfusion, during transfusion, and after transfusion. So before transfusion, an informed written consent is very important, and we have to check the lab values of the patient. And we have to verify the indications and rationale for blood transfusion, and the ABO and RH grouping of the patient as well as the donor has to be verified. Then inspect for any discoloration, clots, leaking, bubbles, or any contamination in the blood bags. And check the unit number on the blood bank and the request form. And check the expiry date on the bag. And once issued, the blood has to be transfused within half an hour. And for routine cases, the availability of blood should be confirmed 24 hours in advance. And we have to motivate the healthy bystanders to donate blood. And if the transfusion is, if a second transfusion is needed after 48 hours, a fresh sample for cross-matching is essential. Now, if for due to any reasons, if blood cannot be transfused within the within a half hour time or any within the time when if the donor's recipient side the patient is not well, his vitals are not satisfactory, then send the unit back to blood bank immediately. Once out of the blood bank will take the blood bags only within 30 minutes if it is returned within 30 minutes. Otherwise, the blood bank returned after 30 minutes will be discarded by the blood banks. And blood should only be released from blood bank just before transfusion. So always make sure that always look the vitals before asking for the blood bags from the blood bag. Now, there is a final check at the patient's bedside. That is the last opportunity to detect an identification error. And this is the common cause of mismatch blood transfusion identification problem. So this prevents a potentially incompatible transfusion. So we have to check the patient's bedside last minute also we have to check it once more. The blood unit has to be discarded if it is out of the blood bank refrigerator for more than 30 minutes, or if the seal is broken, or if you can see any signs of hemolysis, clot, or contamination. Now, during transfusion, we have to monitor the vital signs. Before starting transfusion, 15 minutes after starting, after 1 hour, and 15 minutes after completion of transfusion. And observe for any signs and symptoms of a reaction. And usually, severe reaction is most common during the first 15 minutes of the transfusion. You should also inspect the condition of the IV site, any extravasation or anything like that. Now coming to the rate of transfusion. The rate of transfusion depends upon the blood volume or urgency of the volume replacement or the hemodynamic condition or cardiac status of a patient. And usually the rate of transfusion is red cells, FFP, and platelets are transfused at a rate of 1 to 2 ml per minute for the first 15 minutes. Usually blood is transfused at a slower rate initially because the transfusion reactions are supposed to happen in the initial 15 minutes.